Our project is on the ocular complications of chemotherapy. The eye has generally been considered to be protected from chemotherapy complications. However, recently, newer drugs such as biological agents have led to more adverse side effects. Also, due to bone marrow rescue techniques, higher dosages of drugs have been able to be used, which also leads to an increase in adverse side effects. These effects can be present anywhere in the eye, and due to there being so many, we won't discuss all of them. We're going to kind of narrow down the drugs and the side effects that we discuss. Chlorambucil is used for chronic lymphocytic leukemias and low-grade lymphomas. It's an alkylating agent, so it primarily alkylates DNA so that the molecules break down and cross-link with other strands, which then interferes with transcription and replication. The side effects are rare and generally only occur after several years of oral therapy. Several cases of keratitis have been seen, and one case of diplopia with bilateral papilledema and retinal hemorrhages has also been noted. One man who received treatment for non-Hodgkin's lymphoma was taking 2 milligrams twice a day as a maintenance therapy. After 5 years, he began to notice some visual impairment, which consisted of decreased VAs and constriction of his visual field. He also had pale discs and elevated IOP, for which he was put on timolol. A year later, his VA was worse and other symptoms did not improve, so they reduced his chlorambucil to 2 milligrams once a day. CT of the brain showed cerebral atrophy and his ERG was unrecordable. This suggests a global retinal problem, which would be consistent with drug toxicity. They also ran an MRI to rule out any evidence of the lymphoma returning, which they did not see, so they ruled the chlorambucil as the culprit of his symptoms. The nitrosurias, such as carmustine and lomustine, are used for Hodgkin's and non-Hodgkin's lymphomas, brain neoplasms, multiple myeloma, malignant melanoma, GI malignancies, and bone marrow transplantation. It is also an alkylating agent, which can penetrate the blood-brain barrier and the blood-retinal barrier. Ocular toxicity is rare when given through IV, and most of the symptoms noted are ipsilateral following intracarotid infusions. The incidence depends on the dose, the number of injections, and the speed of the injection. Some fundoscopy findings that are noted are arterial narrowing, nerve fiber layer infarctions, intraretinal hemorrhages, and disc edema. Supraophthalmic arterial infusions have been tried instead of the intracarotid subophthalmic perfusions. No ocular toxicity was generally seen, but 80% of the patients developed delayed cerebral necrosis. One patient also reported ipsilateral blindness with contralateral temporal hemianopsia secondary to degeneration of the optic nerve. In one case of a 28-year-old male with astrocytoma, he was receiving intracarotid infusion of 500 milligrams carmustine over 4 minutes into his internal carotid artery. He noticed pain and erythema of his left eye, which resolved within 48 hours, but he also noticed blur that did not resolve. On follow-up visits, his EOMs became restricted in all of the gazes, and his recti muscles were enlarged. He also showed macular edema, disc edema, and hemorrhages. He developed a constriction in an arteriole that supplies the maculopapillary bundle. Eventually, his VAs declined to finger counting, and he developed optic atrophy as well as retinal neovascularization and vitreous hemorrhaging. Cisplatin is used in ovarian, testicular, head and neck, GI, breast, and lung cancers, and is another alkylating agent. In a study of patients receiving high IV doses of cisplatin daily for ovarian carcinoma, 8 out of 13 experienced blurred vision and 3 experienced color perception issues. In 6 of the 13 patients, there was an irregular macular pigmentation that was assumed to be due to RPE changes. When therapy was stopped, the blur resolved, but the color perception issues remained for up to 16 months in some of the patients. Intracarotid infusion has been shown to cause ipsilateral visual loss due to ischemia, cavernous sinus syndrome, and pigmentary retinopathy. There's one case of a 39-year-old woman with glioblastoma multiforme who was treated by intracarotid infusion, and she showed uveal effusion with exudative retinal detachments, enlarged recti muscles, and inflammation of the surrounding soft tissues. Carboplatin is a child compound of cisplatin, and it's 45 times less toxic than cisplatin. It's used for ovarian cancer and off-label for bladder, testicular, and stomach cancers. Some of the adverse effects with carboplatin are sore eyes, blur, cortical blindness, maculopathy, and bilateral optic neuropathy. The plant alkaloids are used for hematological malignancies, and they inhibit tubulin polymerization into microtubules. In a study of 40 patients treated with either vincristine or vinblastine, 50% developed ptosis, 45% had cranial nerve palsies, 15% developed leg ophthalmos due to a cranial nerve 7 palsy, and 10% developed corneal hypoesthesia. The incidence of these effects was dose-related and tended to develop after about 10 weeks of therapy. Improvement was noted in 2 to 24 weeks for 75% of the patients when the treatment was stopped. There's also a higher incidence of cranial nerve palsies in patients with hepatic dysfunction because they cannot appropriately inactivate the vincristine. It has also been reported that vincristine has caused optic neuropathy in 3 patients which have been treated over a 14-month period. The symptoms in these patients consisted of poor VA, decreased light reaction of the pupils, poor color vision, and pallor of the optic disc. There's also a report of 1 patient with bilateral optic atrophy and blindness due to plant alkaloids. And vincristine has also been reported to cause night blindness and transient cortical blindness. Corticosteroids are typically used in conjunction with other chemotherapeutic agents, not so much on their own, for lymphomas, leukemias, multiple myelomas, and solid tumors. They inhibit arachidonic acid pathway, which then disrupts the inflammatory cascade. And their dosage and duration of therapy determines the incidence of some of the side effects, such as posterior subcapsular cataracts, as well as the underlying disease and ethnicity of the patient. Hispanics are more likely than whites or African Americans to develop posterior subcapsular cataracts from steroids, and the incidence is around 10 to 40%. There's also an IOP rise with secondary open-angle glaucoma in about 30% of patients. Opportunistic infections can occur with systemic use, such as Candida endophthalmitis, CMV retinitis, and ocular toxoplasmosis. So if a patient who is undergoing chemotherapy comes in and they appear to have a posterior uveitis, all of these must be considered as a differential. Topical steroids have also increased the incidence of Pseudomonas corneal ulcers, chlamydia trachomatis activation, and fungal keratitis. Exophthalmos has also been seen. The taxanes are used for breast cancer, and they result in the formation of abnormal and excessively stable microtubules. During a 3-hour infusion, some patients have noticed photopsia in the last 30 minutes that can last anywhere from 15 minutes to 3 hours afterwards. Optic nerve disturbances were reported in 3 patients who received a 3-hour infusion every 3 weeks. These patients reported seeing flies in their visual field, and fundoscopy showed unilateral parapapillary atrophic areas with an abnormal VEP and a normal ERG in 1 patient. In 2 of the patients, fundoscopy and ERG were normal, but they had an abnormal VEP. These patients also had impaired VA. 5-fluorouracil is used for solid tumors such as found in the GI system, breast, head and neck, and ovaries. It interferes with the synthesis of nucleic acid. The antimetabolites from this drug are secreted in tear film, so most of the adverse effects are apparent on the conjunctiva, the cornea, and the eyelids. And this ocular surface toxicity is seen in about 25 to 38% of patients and consists of blur, pain, photophobia, excessive lacrimation, irritation, conjunctivitis, circumorbital edema, keratitis, and cicatricial ectropion. It tends to resolve about 1 to 2 weeks after treatment is stopped. Neuro-ophthalmological toxicity is much more rare, but after superficial temporal artery infusion in 68 patients with paranasal sinus carcinoma, 17% became visually impaired and 8% had a complete loss of vision.
The next drug that we're going to discuss is cetirizine, and this is used for hematological malignancies, which includes leukemia, acute myeloid leukemia, and lymphoma. It is a nucleic acid and synthesis inhibitor, and it's specific to the S phase. Some of the adverse effects that it can lead to are cerebellar ataxia, double vision, locked-in syndrome, which is a syndrome which causes patients to be awake and conscious but completely paralyzed. The most common cause of this syndrome is damage to the ventral pontine in the brainstem. It may also lead to myelopathies, cognitive decline, encephalitis, or papilledema. There is a noted case of a 12-year-old boy who was diagnosed with acute myeloid leukemia. They chose to treat him with a combination of chemotherapeutic agents, one of them being cytarabine. And after his first round of treatment, the patient had right appendicular ataxia, gait abnormalities, and nystagmus. They chose to perform a CT scan to make sure that they hadn't missed any lesions, but there were no abnormalities that were observed. The ataxia gradually improved a few weeks after his first round of treatment. After his second round of cytarabine, the patient exhibited slurred speech, he had complaints of double vision, and the ataxia had reoccurred. They chose to withhold the cytarabine from his third round of treatment, and the patient did not develop any further deficits. This proved to them that cytarabine was the source of the symptoms. 2 months after his treatment, the patient was referred for a neuro-ophthalmic consultation, and upon examination, he showed horizontal pendular nystagmus. He had a right exotropia and a hypertropia, which were not noted prior to treatment. He had hypometric vertical and horizontal saccades. He also had a positive Romberg's test, meaning that the patient lost balance when his eyes were closed. He also had hearing loss in the left ear. They decided to perform an MRI, which is shown here in the picture on the slide, and that showed hyperintensities in the dorsolateral midbrain at both the superior colliculus and the superficial lateral tegmentum, which was secondary to the cytarabine. His hearing loss, ataxia, and ocular motility deficits never recovered. The next treatment is allogenic bone marrow transplantation, and this is used for acute leukemia. And most of the side effects that occur from bone marrow transplantation are secondary to the toxicity of the chemotherapeutic drugs, which are used prior to the procedure. Patients can have complications of infusion, and most of these are thought to be secondary to DMS, which is used as a preservative during the infusion, and also the immunosuppressive agents, which are used during the infusions. Some of the symptoms that may occur are reversible posterior leukoencephalopathy syndrome, and this involves the cerebral and white matter and leads to symptoms including headaches, nausea, visual disturbances, cortical blindness, and focal neurological deficits, depending on where the lesions are located. It's thought to be due to dysregulation of the cerebral vasculature secondary to the toxicity of the agents. But if the syndrome is diagnosed early on enough and the causing agent is removed, the symptoms may be reversible. Other complications that may occur are stroke, increased intracranial pressure, and visual hallucinations. And this image here shows classic posterior leukoencephalopathy syndrome. It shows that there's bilateral signal abnormality on FLAIR MRI. The most significant complication of allogenic bone marrow transplantation is graft versus host disease, and this is the leading cause of non-relapse mortality in bone marrow transplant patients. And graft versus host disease has been reported to occur anywhere from 40 to 70% of patients, and the eye is involved in 18 to 47% of all of these cases. Patients may have anterior segment findings, which include keratoconjunctivitis sicca, which is the most frequent ocular complication of graft versus host disease, and many of the other ocular surface complications are secondary to the severe dry eye, and some of those include conjunctival scarring, filamentary keratitis, SPK, and corneal ulcerations. Patients may also present with lagophthalmos, entropion, and matarosis. This slide shows some images of patients presenting with anterior segment findings secondary to graft versus host disease. This first picture shows conjunctival scarring. The middle image shows a patient with keratoconjunctivitis sicca and filamentary keratitis. And this last image is a patient presenting with entropion and matarosis secondary to the graft versus host disease. Another complication that these patients may have are pigment disturbances cutaneously, which is shown in that last picture as well. There are some neurological complications that may occur secondary to the bone marrow transplantation. One of those is myasthenia gravis, and it typically onsets after tapering or discontinuing the immunosuppressive therapy. Another one is Guillain-Barré syndrome, and this is an immune system attack on the peripheral nervous system, which leads to peripheral neuropathies, and patients may also experience immune-mediated encephalitis. There are also posterior segment complications which may occur, but these are much less common than anterior segment findings. And some of these include ischemic retinopathy, hemorrhagic complications, microvascular retinopathy, retinal lipid deposits, bilateral disc edema, vitreous and retinal hemorrhages, retinal detachment, and infectious retinitis. This next therapy that we're going to discuss is tamoxifen, which is an estrogen antagonist and interferes with the binding of estradiol. It's used in breast cancer treatment, and some of the adverse effects that it has been known to cause are reduced visual acuity, color vision disturbances, optic neuritis, and corneal opacities. It can also cause crystalline retinopathy and cystoid macular edema, which are probably the most common side effects of tamoxifen ocularly. And crystalline retinopathy is simply intraretinal refractile deposits that are in the perifoveal area. And even though this drug is known to cause this, the retinopathy itself doesn't begin to present until doses are greater than 240 milligrams per day, but all of the current anti-neoplastic treatments begin at 20 milligrams a day and increase as needed. So it's not as common as it is associated with the drug to be. This top image shows the crystalline retinopathy and how the deposits are placed around the macula. The next image is showing CME that has developed secondary to the deposits. And the third picture is a fluorescein angiography of that same patient, which shows the leaking where the CME is located. The next treatment option that we're going to discuss is radiation, and ocular symptoms of radiation most commonly present when radiation is directed at the eye itself. There are several methods of ocular radiation, the first one being proton beam therapy, and this is where a beam of radiation is directed through the anterior segment of the eye and pointed at the tumor or lesion being targeted. This is most commonly chosen when tumors are touching or surrounding the optic nerve. The next method is plaque therapy, and this is where a metal plaque containing radioactive contents, most commonly iodine-125 and palladium-103, is sewn onto the eye for about 5 to 7 days and is eventually removed after that time period. And this is most commonly used to treat choroidal melanoma. Proton beam therapy most commonly leads to side effects of the anterior segment because that's where the radiation is directed through. Some of those side effects include matarosis, eyelid excoriation, corneal neovascularization and ulceration, dry eye neovascular glaucoma, cataracts, and vision loss. Plaque therapy most commonly leads to posterior segment findings. Some of these include cotton wool spots, intraretinal hemorrhages, ghost vessels, exudate, microaneurysms, uveal effusion, and chorioretinal atrophy. And all of these side effects fall under the title of radiation retinopathy. And proton beam therapy can also lead to any of these, but it's just most commonly known to lead to anterior segment findings. The top image shown here is an early stage of radiation retinopathy, and the patient presents with cotton wool spots and intraretinal hemorrhages. The lower image on the slide shows a later stage of radiation retinopathy, and this patient here has chorioretinal atrophy, ghost vessels, intraretinal hemorrhages, and vessel sclerosis. Here is a case of a patient who presented with systemic adverse effects of radiation which was directed at his eyes. He was a 35-year-old man and presented with sudden painless vision loss in his left eye. He has no light perception in his left eye, and his dilated fundus exam showed that he had a white retina with a cherry red spot and box scarring of his blood vessels. His ocular history revealed that he was diagnosed with right optic nerve glioma at the age of 7, which was secondary to neurofibromatosis, and that was treated with external beam radiation. Here is a picture of his fundus, and as you can tell, the macula is much darker than the rest of the fundus, and these are all consistent with a central retinal artery occlusion. They sent him off for blood work, and that came back negative for hypercoagulability states. They sent him off for an MRI, and that showed irregularities in the paraclinoid carotid arteries and stenosis of the left posterior cerebral artery. They performed an arteriogram, and that revealed that the left paraclinoid artery was 50% narrowed at the bifurcation of the left ophthalmic artery. And these findings are consistent with radiation-induced vasculopathy, which is defined as fibrous thickening of the tunica intima with endothelial cell proliferation. And half of all radiation-induced vasculopathy cases are secondary to radiation for anterior visual pathway gliomas. And here is a picture of his arteriogram, which highlights the focal stenosis of the artery with the arrow. To conclude, ocular toxicity is not rare in cancer treatment, but most toxicity is not preventable. However, you can reduce the dose or discontinue specific agents to help with the symptoms, and cancer patients should be seeing their eye doctors regularly throughout their treatment.